Okay. We have everyone in, Hussein?
Yes, sir. Yes,
Okay,
sir. We
I'd
got
like
it.
to welcome everyone to Resnik Grand Rounds Wednesday, November 19th. And as always, I appreciate our resident prosthodontist, Dr. Hussein Tariq, who is a clinical director for ITX Pros. And as you know, he's a wizard at treatment planning these cases and maneuvering around the software. So he'll be helping us as always. We also have Dr. Rick Robinette, who's our clinical coordinator at the Resnik Implant Institute. He will be on to answer any questions. If you have any questions, please put them into the chat room and he will get right back to you on any questions that you may have. With that being said, we usually go through and have a short lecture, but we have 11 arches to do tonight. So I don't want to keep everyone all night. So we're going to go right to the first case. And Hussein, why don't you go ahead and take over and show us the first case?
Yes, sir. And we're going to start with Dr. Nick Adaro. We've got his first case. Dr. Nick, would you mind unmuting yourself, please, sir, and presenting your case to Dr. Resnick?
Hi, Nick.
Uh,
How are you? What do
Good,
we
good. You can
have?
hear me okay?
Yes, yes. So what
Great.
do we have?
So this is a 69-year-old patient who's in good physical health. Actually, she had a bridge on the lower left that she's had for 20 plus years, and the distal abutment decayed, and so I
Okay.
removed the tooth. And that little stub there, believe it or not, that tooth was still good. She wanted to keep it. That little stub actually has a new post and crown on there. The tooth was actually fine. It supported a bridge for 20 years. I thought it could support a crown. So I went
Okay.
ahead and did that. And
Okay.
it's fine.
Okay. So right now you have a crown on 20
Yes.
and you're looking to replace 18 and 19. Is that correct?
Yes. And she is
Okay.
missing number 14 on the opposing, but she wanted some teeth over there. And ideally, occlusally, it'd be better if we move those teeth back, but I'm not going to put one in the 17 position. And
Okay.
so just if we could line a couple teeth up, that would just make her day. She really wants to do that. I've already talked to her a little bit because she's missing some opposing and what have you. So I sent this
Okay.
already to ITX Pros, and there's some questions that were in there, so I just
Okay.
want to share with
So
you.
so let's Hussein, could you remove those two teeth and let's
Yes,
do a
sir.
360 on the 3D and let's see. So Nick, right off the bat, you can see where she's lost a lot of the buccal plate. See how it's resorbed from buccal to lingual?
Yes.
So it's very, very thin there. Let's go ahead and look at the undercut, Hussein.
Hey, I already have to set up a bank account.
Okay.
I had a
And
job,
let's look on the lingual.
but I bought a cheap car, a Toyota.
Okay.
It was only like
There
20.
you go. Perfect. Okay. So, did you go ahead and try two implants in here,
Yes,
Hussein?
sir. I did add two implants at the sides of number 18 and number 19. I'm going to start by presenting the side of number 18, Dr. Resnick. And for this side, I'm using a 5.0 by 8 millimeter long implant with exposure of the colder part of your implant over here to the facial aspect. Then we've got an implant at the side of number 19 where we're using a 5.0 by 8. Both implants are clear away from the mandibular canal, Dr. Resnick. What's your thoughts, sir?
Okay. So let's go ahead and let's look at number 21 first
Oh,
of
Yes,
yeah, I
all.
sir.
saw that. Yep, I saw that.
Okay.
Harl,
Okay.
yep.
Okay. So scroll back and forth on that. So we have a PA lesion. Looks now that could be a scar, but there's not a lot of bone on the facial there. Let's look at 20. And so the 20 you've already restored, correct?
Yep.
Okay. So Nick, here's what I would do. I would just check number 21 and see if you have any past radiographs and see if that lesion's getting larger. If it does, you're going to have to uh, treat that accordingly, possibly with a retreat or a apico on that. Uh, because 20 is already crowned, ideally you want to keep that. So just put that on your list to evaluate just to make sure you don't want to miss anything there. So with that being said, let's look at 18 and 19 again in the pan view. Okay, scroll through. Okay, now let's
That's
go
a
back.
that's a recent endo on 21.
Oh, it is? Okay.
Yeah, it was done and it's much smaller than it was. So yeah,
Oh, it
so
is?
no,
Okay.
yeah,
Okay. Uh, Another thing, Nick, is do you see on what is that 31 over here?
yeah.
31, yes, sir.
Okay, you look like you have a problem there
I
also.
do.
Okay.
I've spoken to her about that already too.
Okay. So you might even probably you're going to lose that too. So okay, just as long as you're aware of it. Let's go back to 18 and 19, and let's look at the 3D image. Okay. So, Nick, right off the bat, I just want to point out a couple things. See how much bone resorption we've had there? So
Yes.
she's missing the buccal plate. Secondly, let's show the anagonial notch.
Here we go, sir.
So this is a female. That's a pretty significant anagonial notch, meaning that she's worn out, that the master's pretty strong there to wear out that bone. So there most likely is some parafunction also in her history. So you want to be very careful with that. Third is the position of the nerve. Let's go back and look at a cross section of that.
Yes,
Or
sir.
okay, right there. So that's even better. So if you can see that, Nick, it's a type 1 nerve. If you remember, a type 1
Yep.
nerve is the higher nerve. It's not the most conducive for implant placement. However, you do have adequate height to place the implants. Number 4, do you see the crown to implant ratio here? So your restorative space is rather large. With that being said, here's what I would do. Let's go back to number 18, the cross section.
Here you go, Professor.
Okay. So, Nick, I think this is going to be too significant to graft at the same time at placement. What I don't like about this, do you see there's a little peak there? Can you show him that, Hussein? Right in the center of the implant. Go right to the top of the ridge. Keep going, right
Oh,
there.
you mean
When you start to do your osteotomy, that's going to deviate you, and unless you do this fully guided, you could perforate the lingual or worse, go out to the facial and possibly get into the neurovascular bundle. Therefore, what I would recommend on this case is do this two-stage. The first stage, do a small bone graft on the buccal, build that buccal out real nice. You'll get a little bit more height there on that 18, and you'll definitely get a lot more width. So if we go back to the 3D image and let's look at it from the occlusal and make that radio opaque. Perfect. So do you see where even 19 is very thin? So
Yes.
if you see how that's really
Yeah.
concave, what I'd like you to do is build that out. Hussein, show them, bring that straight over. There you go. That's what I'd like you to do. Then you have plenty of bone on the buckle. The other thing I would do, Nick, is you can do two 5x8s here, but you should splint them together because of the crown implant ratio. Also, when you give this patient a treatment plan, make sure it looks like there's super eruption on the adjacent teeth. Make sure you put that in the treatment plan that you're going to adjust their opposing occlusion. I believe I saw it on one of
here
those
you go.
images. Yeah. Okay. And I'm just extrapolating that, but it looks like certainly you're going to have super eruption issues there. Okay. Does that make sense?
Perfect sense.
So phase one is going to be
Graft.
a small bone graft. I would definitely use tent screws, but you can actually, you have autogenous bone here right on the external oblique. You can use some allograft and some autograft, build that out real nice. It'll be a very simple graft case because it's concave. Remember, I talked about the catcher's mitt? This is a
Yes.
perfect catcher's mitt. So, phase one would be the graft. Phase two usually will take an x ray between 3 and 4 months, evaluate it. You're probably looking at between 4 and 5 months of placing the two implants. Okay.
Yes, sir.
And then just make sure you check out that number 31, and
I
I think
will.
you're good. Questions on that?
No, that was very, very helpful. Thank you so much
Okay,
for your time.
great. Good luck. Let me know if you need anything on that. Take care.
Okay, thanks.
Okay. Okay, Hussein, who do we have?
Next case,
Number two.
professor, is for Dr. Maggie Augustine. Dr. Augustine, would you mind
Okay,
unmuting
Maggie
yourself,
always
please?
has something interesting. So is Maggie on?
Yep, I'm right
Yes,
here.
sir.
Thank
Hi,
you.
Maggie. How are you?
I'm good. Thank you. Thank you for doing
Okay.
this.
Okay. What do you have for us today? Ooh.
So I have this
Okay.
case here, and this is a patient that is in his 50s, and he has been told for a very, very long time in our practice that his implants are failing. He didn't really want to do anything about it, and now he's finally deciding to do something about it because of the super eruption with what appears to be super eruption number 8, and he doesn't like how that looks aesthetically. So he's also kind of a price dropper, so he went to see an oral surgeon. And the oral surgeon said, "There's no issues. I'll rebuild you. I'll take the implants out. I'll do the bone graft. I'll put the implants in." He came to me for a restorative consult, and I said, "Look, there's a really high chance that I cannot make these teeth the same size. That one tooth is probably going to be at least 10 millimeters longer than the
Yeah.
other." And I also had the same discussion with the oral surgeon, and the oral surgeon said, "Huh, that's interesting. I never thought of that." And this
Okay.
guy
Yeah.
has been doing that for, I mean, he's probably in
Yeah.
his 60s, right? So okay, so the patient lost some trust in the oral surgeon because this information was not presented to him. I told him this is an extremely challenging restorative case. I don't know where the implant's going to be placed, so I don't know how the angulation is going to be. So then he came back and he said, "Well, could you do this instead?"
Okay.
When I talked to the oral surgeon, and I know everybody has their own protocol and armamentarium, the oral surgeon did not think that there should be any mesh or any tacks or anything like that placed to do the bone graft. And if you look at the CBCT, there's barely any bone there. So the
Okay.
question becomes, the implants do not look terribly difficult to remove, but they are older implants.
Yeah.
Um,
Okay.
and so my question is this a case that I should be looking at?
Okay.
I suppose that's the biggest question for me.
Okay. So let's look at some cross sections here. Hussein, do you have some cross sections for me?
Here you go,
Let's start
professor.
at number 8. Could we start at number 8? Let's look at what that tooth. And Maggie, number 8 is failing. Is that correct? Or it's failed?
No, it's not failed. It's there.
Yeah. No, but I mean, it is it restorable?
Yes, yes.
Okay. But you said it's super erupted.
No. I'm sorry. I meant number 9. The natural tooth has super erupted next to it, which is what's making him dislike the aesthetic. So the implants are the ones that are failing.
Okay. So,
So
okay.
number 8, the natural tooth.
Has super erupted.
I believe so. Yeah, at some point because they were equal and now they're not.
Okay. And number 9 and 10 are implants.
Correct.
They would not super erupt
Correct.
because there's still bone around it. So number 8, just scroll through that. Okay, keep going. Okay. Um, okay, let's keep going. Do a cross section on starting on 8 and go right to 9
Here
and
we go,
10.
professor. Here is number 9, sir.
Okay.
And that's simple number 10.
Okay. Let's look at it from an axial view. Could we? This one is Maggie. You always bring the fun ones, don't you? Okay. Okay. Let's go apically. Keep going. Keep going. Keep going. Okay. Back superiorly. Keep going. Okay. Good. Okay. Now let's go to the pan view. So here's what you have, Maggie. Um, I see what you're talking. Go back. Keep going. Go back the opposite way. And keep going, keep going, keep going, keep going. Okay, good. Okay. Uh, Maggie, let's get a better view of this for her. So, or let's go to the 3D. Just go to the 3D. It'll be easier.
Here we go, Professor.
Okay. So, Maggie, let me tell you a couple things I don't like. I agree with you. I think number 8 has super erupted. The question is, why is it super erupted? You've lost bone around it. It does look like you have the starving apical pathology. Is there mobility to number 8?
No.
There isn't. Okay. So I don't think 8 is as healthy as it may look. So there might be some inherent issues. See, there's some bone loss there
Yeah.
on the mesial. And what I don't like about this case right off the bat, and I believe you addressed it right at the beginning, is the aesthetics of this. This is going to be a catastrophe aesthetically. It's going to be an FP3 plus. Okay, so if you look at where the bone, where the basically the CEJ is compared to where the bone level is, it's rather significant. So they're going to be really, really long teeth. And so you're going to have natural teeth on 6 and 7. 8 is going to be a little bit elongated. 9 and 10 are just going to be huge. And 11 is going to be slightly elongated. So I don't like the aesthetics of this. Secondly, you asked me, is this a case you should tackle? Let me go back. Let's show her the cross sections on 9 and 10. So, Maggie, these look to be what is called a press fit implant,
Hmm.
okay, which look to be Calcitech implants. So, see those little apical
Yep.
openings?
Yeah. Right.
Okay, you have bone that's grown
Growing
through
through
there.
it. Yeah.
Those are They're a nightmare to remove these implants because you have to cut the bone away. So the only way to get these implants out, I know what your oral surgeon told you. That's not the way it works. What will end up happening is you will end up taking a ton of bone away. You'll have to use a trephine,
Hmm.
and this will be very traumatic. You're going to lose the whole buccal plate. You're going to lose a lot of the lingual bone almost into the nasopalatine.
Yeah, I can see
You
that.
you have to get all the way to the apex of that apical vent to sever the bone that's grown through
Growing
there.
through.
And they're nightmares to remove. So you've heard me say, how much do you charge to
Yep.
remove someone
Triple.
else's implant? You triple it, then think of not doing it. Well, this is one of those.
You think
So
you don't do it.
let me give you another option here, Maggie. Let's go back to the 3D image. And I know you're probably going to think I'm nuts on this, but let me give you another way out of this case. Um, I think let's look at it straight on.
Hey, Google,
Oh,
turn on the
frontal.
bathroom light.
Okay. Okay, Maggie. So here's what I would say is an alternative option to taking the implants out, grafting, which is going to be very difficult, if not impossible, but your aesthetic result is going to be downright horrible, is to cut the crowns off of those implants. You seal the top of the implant, let the tissue go over top, and you do a 6 through 11 fixed partial denture. Aesthetically, it'll look the most congruent and probably the best that you'll do on this case. So aesthetically, I think you should at least have that conversation with the patient. It would be the path of least resistance. You could leave the implants in, just go ahead and reduce them to the level of the bone and seal them with
So
some.
no cover screw, just kind of.
Well, you'll drill through the threads. So all you do is
Oh, so
take
you
some
go in, you cut
Yeah,
them off at the bone?
you cut them off at the bone, definitely, yes, because you don't want to leave any implant above the bone
Got
because
it.
it'll
Mhm.
continue to lose bone. If you cut it off flush, they'll stay there forever. The only thing is you have to seal it because you'll get a
Like a
bacteria,
pocket or pus, yeah.
and all you do is put composite, polish it real well, and call it a day, and it'll be fine. It'll maintain that bone, actually, is what it'll do, Maggie. And then you can make a nice 6 unit fixed partial denture, and the guy will love you. Anything other than that, this is going to be on a scale of 1 to 10, this is a 35 difficulty. Okay. And it's, it could be also impossible to build that bone. And remember, Maggie, you have to build soft tissue back up too.
Yeah, and
So,
I found it really interesting that the oral surgeon just did not consider this to be
well, because they're looking at it from a different point of view. They're looking at, I'll just go in and rip these implants out. I mean, look how close it is to the nasopalatal.
right.
I mean, by the time you get that out, you're going to be into it. That's why I don't want you to take them out, because there's so much morbidity can happen from that. And if you ever have to take them out in the future, you can leave the bridge in. All you do is make a vestibular incision and take them out from the
From
buckle.
the side.
If you, yeah. So I think what you should need to do is re-educate the patient. And I think you could do a real nice 6 unit bridge that would look probably very acceptable to the
Well, and
patient.
it'll cost so much less
It'll
compared.
cost, and you can do it in a day.
Mhm.
You can get a temporary prosthesis in there in a day. Okay. So it's probably not what you wanted to hear, but, or maybe
No,
what the
this is fine.
patient didn't want to hear.
Yeah.
But I would, trust me, taking those implants out, my gosh, I can't even tell you how horrible that will, it's not easy in anyone's hands. I don't care who's doing it. It's not a good day at the office because he's going to have one huge defect and a ungraftable defect.
Okay. Okay. Thank you.
Okay.
Thank
You
you,
like
Frank.
it? Okay, Maggie, take care. Have a good day. Okay, Hussein, let's see if we have more interesting cases. Who do we have up?
So next is Dr. Tom Ho. Doc, would you mind please unmuting yourself and presenting your case to Dr. Resnick?
Hi, Doc. How are you?
Good. How are you, doctor?
Good, good. You always have good cases too. What do
Oh,
you have
well,
for us today?
thank you. Yes, I do have a patient, male, 61 years old,
Okay.
and medical history. He is diabetes. It's well controlled. He's taking metformin 500 milligram, and he's taking atorvastatin.
Okay.
So Eliquis, 5 milligram BID, because he has a very mild heart attack about 6 months ago. So the doctor placed him on Eliquis,
Okay.
and
Okay.
I confirmed with him about his A1C is 6.3, and also his primary care says if he needs some dental procedure surgery, he can take off 2 days of Eliquis.
Okay. So here's what you want to do. You want to send the physician that medical clearance form
Yes.
and make sure this patient had a heart attack in the last year. Even though they said that it wasn't bad, you don't know how much damage was done. You
Okay.
need that to be evaluated. Secondly, always get the physician's position on what the A1C is. So sometimes patients get that wrong.
Okay.
The patient will need to come off Eliquis. As you remember, let the physician take them off. Usually they'll want them right back on, but let them take care of that. If they want them off 2 days before, have them take care of that with the patient.
Okay.
Okay.
Thanks.
With that being said, you have an upper and a lower. So why don't we start with the upper? So it looks like we have missing number 3, and that's what you want to replace?
Mainly is we when we extract number 15, we might do some enamelplasty on number 14 and 2 implant on 19 and 30.
Okay.
And implant on number 3 is also an option or a 3 units bridge.
Okay. So let's first look at number 3. How about give me a cross section there?
Right away, Professor. Here we go, sir. So the
Okay.
vertical height of bone, Dr. Resnick, over here is approximately
Partially.
3.8 millimeters, sir.
Okay. So, Tom, right off the bat, that's going to be an SA4. So
Yes.
you would need a. Let's look at a pan view of this real quick. Okay. So, Tom, your options are going to be SA4, delayed implant placement, single implant, or a 3-unit bridge.
Right.
As you remember, the SA4s are very difficult, or a lot more difficult when they're one site. So when
Right.
they're in between teeth, they're a little bit more difficult. But
Narrow space. Yeah.
yes, so but it's certainly an option. A fixed partial denture is also an option. So I would give the patient the options, those two options basically, and let them decide. If there was more bone, it would be more advantageous to do the implant because you have compromised bone right off the bat. It's going to extend that treatment plan, almost up to a year before you
Oh,
could get a tooth in there.
all right.
Okay.
Thanks. Yeah.
Okay. Now let's look at the other side. You said you're going to take out 15. Is that
Yes.
correct?
Yes.
Okay. And did you want to put an implant in on 15?
No.
Okay. That's good because you have no bone and you have a big infection on the
Right.
apex. Okay. So you don't want to put any implants on that side.
No. No. Only on the lower number 19.
Okay, so you want one implant on number 19
Yes.
because you don't have number 15 anymore. Is that
Right.
right? Okay.
Yeah.
Okay. So let's take a look on the lower. And it looks like, is this the patient's lower, Hussein?
Yes, sir. I'm loading the lower
Okay.
arch right now, Dr. Resnick.
Okay. So, Tom, what Hussein did is he put two implants in just so that for time purposes, just in case. So let's just, even though you said only one, let's just see what you have here.
So
Um,
I did add two implants, Professor. A 5
yeah.
by
So
10
is
at
that
the side of number
number
80,
okay? And
18, sir.
let's go 19.
A 5 by 10 at number 19 side as well, Professor.
Okay. So let's look at it on a pan view. Okay. So if you keep, okay, so here's another option. Tom, if you're keeping 14 and you're going to do an
And
enamelplasty,
then,
you
yes.
could most likely do two bicuspid implants,
Oh,
and that would give you more chewing surface area. So just like what he did on the right side, you could do
yeah.
two 4.3s and two bicuspids, or you could do two 5.0s. So what I would say is you can do one or two implants on the left side. You don't need any bone grafting, straightforward. I would probably at least do a pilot guide on those so you can get the ideal position, and I think you would be good to go. Your
Great. Great.
nerve is relatively low. It's a
Yeah.
type 2 nerve. You have plenty of bone. So you could do one or two implants.
Great.
Okay? Does that
Great.
make sense?
Yes. Yes.
Okay, let's go to the right side now and see. So I assume you did two 4.3s because of the spacing.
Yes,
Hussein, is
sir.
that why? Okay.
We've got a remaining groove, Dr. Resnick, distal to the side of number 31 over here, sir, that I wanted to present to you for your feedback, Doc. Here you go.
Okay.
That's the remaining groove I was trying to
Mm.
avoid. So I went ahead with two 4.3s by 10 at the size of number 30 and number 31, sir.
Okay. Tom, are you planning on keeping 32?
Ye I think so. I'm
Okay.
not thinking
Okay.
of in that.
Okay. Let's look at a pan view on this.
Here we go, Professor.
So what he did here was very intelligent. He went down to a little bit smaller implant diameter, so he avoided that root tip, and also because of the tilting, that mesial tilt of that third molar, it's going to give you a better prosthesis. So I
Oh,
think his plan there is ideal. I believe you said you only wanted one implant there. But if you replace number three, you're going to probably want two implants.
Right, right.
Yeah. So I would do his exact plan there where he has them positioned. It's a nice positioning. You're far away from the
The-
nerves. So I think you would be in good shape with that plan
Great,
as is.
great, great. Thank you so much.
Okay. Okay. Take care, Tom. Have a
Right.
good
Yeah,
day.
you too. Thanks, you too. Bye.
Okay. Who's next?
So I'd like to check if Dr. Mahima Gupta is onto the meeting. Dr. Mahima, are you onto the meeting, doctor?
Dr. Gupta? No?
Perfect. So, Professor, next doctor is going to be Dr. Aaronstein. Dr.
Okay.
Aaronstein, would you mind unmuting your mic and discussing or explaining your case, Dr. Resnik, please?
Hi.
Okay. Hi, Doc. How are you?
Hi, how are you?
Good. So it looks like you have an upper and a lower. Is that correct?
Yes, so it's a 71-year-old male patient, healthy, reports no medications, no allergies. He's lost the lower teeth um, quite a long time ago and upper teeth within the last year. Um, um, there was no grafting done at the time of the extractions, and
Okay.
now he has some implants on lower anterior, so he kind of is happy with that. And he wanted to go implants, but we did discuss possibly doing partials as well because of the severe resorption.
Okay. So let's take a look here. Let's first take a look at the maxilla. So the
Hmm.
patient's missing two and three. You're looking to
Yes.
replace these teeth. So, Hussein, can you give us a sagittal or a cross section here?
Here we go, Professor.
Okay. So, okay.
The vertical height of bone, Professor, is exactly 4.2 millimeters.
Okay.
4.3,
Let's
sir.
scroll back and forth there. Yeah, and it might be a little bit less there. A little root tip there also.
Yeah.
Where's that at? Um,
It's distal to the side of number two, sir.
okay. Okay. So, Doc, you want the good news or the bad news? Let me give you the bad news first. You don't have enough. As you remember the SA3 versus SA4, we need at least 5 millimeters of bone. And once you start to perform the osteotomy, you're going to have probably three left over. So that's the bad news. The good news is you have some really good inflammation there. So you have an inflamed Schneiderian membrane, which would make grafting in this case rather easy for you. So if you look at the panoramic view,
By the way,
if
Professor, here we go.
yeah, so this would be a straightforward sinus. It's basically a flat floor with some nice inflammation. So you wouldn't perforate. It would be a rather easy one, but it would be an SA4. So your options are SA4, two implants, delayed implant placement, and then I would splint those after the implants are placed. The other option would be a partial, but unilateral posterior maxillary
Yeah.
partial is they're not very
Yeah.
accepted. So I would look at if have you done any sinus grafts, Doc?
No.
Okay.
No.
This would not be a bad one to start. So if you were looking for a good beginning case, this would be a good one. Okay.
Mm-hmm. Mm-hmm.
And I would recommend that you do it. Um, Hussein can make you a guide, just like at our course, what you did it'll make the window right over the area and it'll make it very, very easy. So that would be the ideal treatment. So
Mm-hmm.
graft, delayed implant placement, then two implants, and then the prosthesis would be two splinted crowns.
Mm-hmm. Okay.
Okay.
Yeah.
Okay. Questions on the maxilla?
No. No, that
Okay,
sounds good.
good.
Hmm.
Okay, let's look at the mandible. So now I believe you said the teeth were taken out a long time ago
On
and there
the,
was no
yeah,
grafting done. Is
no.
that correct?
I believe not. I mean, in the side of, I guess it's a 31, there's that area which I'm not sure if it's just like a either it's a dense bone island or just but maybe he had a grafting done a long time ago.
Okay.
It
Okay.
looks weird, but nothing that he can remember.
Okay. So we're only looking on the right side, correct?
Mm-hmm.
Okay. So right off the bat, Doc, do you see there's some osteosclerosis here?
Yes, yes, that
Okay.
area. Yeah,
So ideally, that's not a contraindication, but we try to avoid those areas if
sure,
possible, just because there's not a lot of blood supply to that area. It's harder bone, so it's a lot easier to burn the bone or
sure.
have become necrotic. So, Dr. Hussein, what did you do on this case?
So we got multiple different plans for this patient, Dr. Resnik. So the first setup we came up with is like two molar size crowns and a premolar over here to close the space, edentulous space we've got over here. But one of the difficulties that we met with this one, Dr. Resnik, was the mental framing position at the
Yes.
site of tooth number 29, sir. So let me show you how the mental framing is looking over here, Professor. I'm going to
So,
switch off.
so this is a good, hold it right there. Go back. Okay. So, go one click back. Okay, right there. See the position of the actual nerve in the body of the mandible, and then look at the mental foramen. So this is rather significant. That's called the mental canal. And
Mm-hmm.
this is a extremely large one. It's almost I would call it a variant mental foramen because of the position of that compared to actually where the neurovascular bundle is. So with that being said, when you see this, and it's usually in the first bicuspid area, you see this, that usually makes it very, very difficult to place an implant in that area. So, did you try to place an implant there?
Yes, sir, I did. So I went ahead with a 3.5 by 8 millimeter long implant, Professor. But as you could notice, Professor, right now, away from
Yeah,
where the mental framing is, it's really
Mm.
tight, sir.
yeah, I don't like that right off the bat. So let me see that on a pan view. Yeah. Okay. Do you see that? That's going to be way too close. That's not worth it. So, uh, see how high that is? Wow, that's extremely high. So, what is plan two?
Plan two, Dr. Resnick, is because of that rotated bicuspid tooth. We're planning on doing a full coverage restoration for tooth number 28, sir, and restoring the remaining edentulous side like a two molar size crown instead of a bicuspid molar and a molar, Professor. I'm loading the treatment plan right now for you, sir.
Okay. So, let me explain what they did here. So, this is a good idea. What they're looking at is because of this bicuspid, remove that mask over the bicuspid. So see how that first bicuspid is tilted? So it's almost auto rotated. And because of that, that is basically out of position. So what they did here is a very good idea. There, the only disadvantage of this treatment plan is you would have to crown that bicuspid. So go ahead and crown it for us, Hussein.
Here we go, Professor.
So you can see he crowns it and then he just over contoured the distal a little bit.
Mm-hmm.
What that
Mm-hmm.
did is that got us away from that mental foramen. And then let's see where the implants are on a cross section.
So here we go, Professor. That's our first implant, the one we're calling number 29. It's a 5.0 by 8 millimeter long implant at that side. And I'm going to rotate around this one, Professor, just to show you the
Okay,
relationship
that looks good. Plenty of
later.
bone
Okay.
there. Okay.
Then we've got number 30, sir, a 5 by 8 as well, staying clear away from this osteosclerosis distal to my fixture, doc.
Okay. Okay. I'll tell you what, I like that treatment plan. So, do you see the contour of the crown? This way, you don't have a cantilever, and both of those implants are far away from the canal and also that osteosclerotic area. So, I think that's a very, very good plan. I like it. What do you think, Doc, on that one?
Um, yeah, would you split them still?
Yes.
Split
I
them?
would.
Mm-hmm.
The only reason I split them, Doc, is because the crown implant ratio is going to be,
Yes.
especially on the distal implant, it's not going to be ideal. And you'll never go wrong splitting them. If there is a force related issue, then you could have a complication. So I would just go ahead because this one is not the most ideal anatomy. So I would split them.
Mm-hmm.
And this way, you stay away from that mental framing, and this is a good plan. I like it.
Mm-hmm.
Okay.
Thank you so much. Yeah, sounds
Okay,
awesome.
Doc. Okay,
Thank
good.
you.
We got some great cases here. Okay, who's up next?
Next case is for Dr. Maria Benefield. Doctor, would you mind unmuting yourself and presenting your case to Dr. Resnick, please?
Maria, how are you?
Good. How are you?
Good. She always has good cases too. So, what do you have for us today?
So I have this patient. He has actually been edentulous for many, many years, 20 plus years on the lower, number 19, number 30, 18, and 19. I played around with positioning implants. I just did not see how 30 was even an option because of the proximity of the nerve. But I thought, well, let me present it. 18 and 19 definitely splitting them because of the crown to root ratio. So just wanted to get your
Okay.
thoughts.
Okay, so let's first look at 18 and 19. So right off the start, Maria, you can see we've lost the buccal plate there.
Mhm.
So Hussein, did you put some implants in?
Yes, sir, we did. So I did add 3 implants for the mandibular arch. I'm going to start with number 18 to start with, Professor. It's 4 by 8. I've got significant exposure over here to the facial aspect. Then we've got number 19, a 4 by 10 with significant exposure over here to the labial aspect as well. And last, Dr. Resnick,
Okay, here,
is the
let's just do 18 and 19 first
yes, sir.
so we don't confuse things. Okay. So Maria, I like where he has those positioned. The only thing I don't like is the bone, where you've lost so much of that buccal plate that that is not ideal, unless we put those implants in at a lingual oriented trajectory, which you don't want to do. So with that being said, let's look at the 3D image. And let's go ahead and remove the implants. Okay. And let's look on the facial, from the facial. Okay. So can we make that translucent?
Right away, sir.
Okay. So Maria, you have a good nerve. So that's a type 2 nerve, which is good. The height of the bone vertically is a little bit compromised, but not bad. So I think you're going to be fine. The only problem is horizontally you're compromised. So you're going to need a graft. So this is one that I would say it's definitely too much graft to, or it's too unpredictable to place the implants and graft at the same time. I would do a GBR here. I think it would be a very easy GBR because you do have that concavity and you do have access to the external oblique there. I think it would be very simple to do and it would be a good case.
Okay.
So this would be one. Let's look at it from the occlusal again. Okay, can you make it opaque? Okay.
Here you go, sir.
Okay, perfect. So Maria, this one, we've been playing around, Hussein and I, with one of these these tent screw guides.
Mhm.
So if you would want, this would be a perfect case to use a guide where it would be two
Okay.
supported. And you remember how you use fixation pins for like an all-in-X case? It would be the same exact type of guide where you would pre-drill all your tent screws
Okay.
and then you pre-drill them, you take it out, and then you just insert the tent screws and then go ahead and graft. It would be simple, easy. And we would design the position of the tent screws. Basically, it's dictated on where you want to grow the bone.
Nice.
So, and that is dictated on where the implants are going to go and where the prosthesis is, according to the maxillary arch. So that would be, I would say, two implants delayed after GBR, and it would be a great case. I think that would be a good one.
How does the GBR look on 30? Is that an
Okay,
option?
so
I know
let's look at the other side because one thing I didn't like, and not to depress you on this, is that. Okay,
Yeah, I
um,
know. I saw
I
that.
don't like either of those. So let me go back to the pan. It even looked worse on the pan, I thought.
Mm-hmm. Yeah,
Okay.
there.
So right off the bat, we have number 28,
Hmm.
which is there's a lot going on there that's not good.
Yeah,
And then what I don't like about 29, look at the distal, Maria.
yeah.
Oh my gosh. So you have tons of bone loss. So if you would put an implant in, did you put an implant in on this one, Hussein?
Yes, sir. I
Can you
did
put it
attempt
in
adding.
that pan?
Here we
Okay.
go. 30s.
So look at where, hold it right there. Maria, look at where the position of the neck of that implant is in relation to the distal of number 29. You're at the lower one third, which is not ideal at all. This is going to be a almost impossible to clean. You have a tilted molar there that's going to
Mhm.
make it very difficult to even put a prosthesis in. It's going to be a huge crown implant ratio. Um, let's look at the nerve position here.
It's
And
very close. Yeah, I can't believe you were able to fit an implant.
okay. So actually, it's not bad, Maria.
Not that bad, huh? I couldn't
Yeah.
even get 8 millimeter, but I guess.
Okay. Okay. So, what might be deceiving you is it's the nerve position because this is one of those cases where you do not have a cortical lining around the infraalveolar canal. So they traced it out. What they do is they start the anterior posterior, then they extrapolate it in. So that's most likely where the nerve is. So you do have enough room.
Okay.
Here is what I would probably recommend. Let's go to number 20 and 21.
20 and 21.
I'm sorry, not 28 and 29. 28 and
Yes, sir.
29. Actually, just blow. Okay. So I would take out 28 and 29 and graph those and graft 30 at the same time.
Okay.
And then just come back and do two or three implants if you have to,
Okay.
depending on force factors. And I think this would be a good site also. I think if you try to treat 30 by itself,
Mhm.
I'm not feeling very comfortable with that one. I think you're going to place yourself at risk. You can't even do a fixed partial denture there. There's too much bone loss on
Yeah,
that
that's why he
anterior
doesn't have
abutment.
one.
And number 28, that distal looks like, I mean, you might have decay there. I
Hmm.
don't know what's going on there. So
Yeah, yeah.
I know it's just not good. So I would do phase one,
Hmm.
extract those two teeth, go ahead and build out. You don't have to build out the buckle much on this one at all. The height is good if you stick with an 8 millimeter implant, and then an implant in 28 and or 29 after it heals, depending on force factors. So,
And When you said graft 30, do you mean GBR to try to
Yeah, I would just try to get a little bit more. Let me see that cross
put some
section again.
pins or
It
just
was a little thin,
putty?
I thought, but let's look at it again. Yeah, is that okay? So go click back and forth on this one.
Yes, sir.
Okay. Yeah, I would just try to build that buckle out a little bit. I think it'll make your implant placement a little bit easier. This is one that even you could place the implant and graft at the time. But I think since you have to graft 28 and 29,
Do it
just graft
all.
that one too. Do it all at once. That's what I would do.
I have a question about 28 because I've noticed now with looking through CBCTs, wherever there is a little bit of that puff, which I know we were always taught, let the sealant, the puff, you get a better result. But now I'm seeing a lot of these scarring or
Yeah, yeah. I see a lot of these on
yeah,
CT scans now,
that's what
and
I'm noticing
yeah,
too.
yeah. So I don't want to give you advice on endo. I don't know if I really understand endo that much, but
I'm
I
realizing,
know,
wow, maybe that's not the
yeah,
way to do it.
I don't know if that's the ideal way to do it. Yeah.
You know what? Just
Or
extract and implant. No more endo.
well, this is that's controversial in itself too. So I can tell you on this that as soon as he put up the pan, my eyes went to those two teeth,
Yeah, same.
and those are the weak link.
Mhm.
Remember, I always say teeth can be the weak link. That
Mhm.
is the weak link.
That's
That will destroy that whole case. So get them out of there.
okay.
They have a very poor 5-year prognosis. I don't think that's a good idea to keep those. So,
Okay. Thank you so much.
okay. Any other questions?
No, I hope you guys have a happy Thanksgiving.
Okay, you too. Thanks,
You too.
Maria. Okay, who do we have next?
So next is Dr. Karen. Dr. Karen, are you on to the meeting? Guess not. So next case, Dr. Resnick will be for Dr. Winter. Dr. Winter,
Okay.
are you online,
Uh,
sir?
Yes, I
uh,
am. Can you hear me?
Loud and clear, Doc.
hello, Dr. Winter. How are you?
Outstanding, Dr. Resnick. Good to talk to you tonight. Thank you
Good
very
to
much
talk
for
to you.
taking
And I
this
know
case.
you always
Huh?
have some good cases too. So what do you tell us what you have for us tonight?
Well, thanks to ITX for taking this case because there was a mix-up this afternoon. The
Okay. Great.
24-year-old African American female presents with a chief complaint of an ugly front tooth. Past medical history is really benign. Uh, No known allergies. At the age of 11, she received some trauma to her front teeth. At that time, tooth number 7 was avulsed. A 3-unit bridge was placed between 6 and 8, and endodontic therapy done on 9. Since that time to this age, 9 has grossly failed, and she's concerned about replacing 9. I bring this case for a review as to how to manage the grafting component of this and how to manage the bone. She's a thick phenotype with a fairly low lip line when she smiles, but and she did not have a pre-trauma diastema, but this is her smile line here, and then I think have one in repose of what her natural smile is. So that's I'm a little bit concerned about the aesthetic manifestation of this case. Go ahead.
Okay, so right off the bat, Doc, she has a rather high smile line, which concerns me a little bit. I if I look at her smile line, let's not even talk about number 9 because I know that is not in the ideal position. She does have a fixed partial denture from 6 to 8. Those teeth are sound. Is that correct? There's no problems with 6 to 8.
Yeah, at this time, no, we're not having any trouble
Okay.
with that.
Okay. Uh, and there's no problems with 10 or 11.
No, sir.
Okay. So if I look at her smile, look at number 7 versus number 10.
Uh-huh.
Okay. Do you see a significant difference?
Sure, there's yeah.
Okay. So she doesn't have a congruent smile, mainly because she has a bridge on the right side and natural teeth on 10 and 11. So just remember that when we get to the final treatment plan. So let's go back and see what number 9 looks like, because I believe you said you were questioning how this was going to be grafted. Was that right?
That is correct.
Okay, so let's go ahead and make number 9 full screen
Yes,
so we
sir.
can see what cross section wise. Okay, so let's start on one side and scroll through. Wow, now I see why that is. She lost the whole lingual of the tooth.
Yes, sir. We've got the only thing we've got is bone apically. I mean, I'm really concerned about
Yeah, so
the whole thing.
Hussein, don't move this, but can you draw the bone, what's going to be left after the extraction? Okay, come straight down and then stop right there. No, that's going to be gone. Once you get, so if you look at where this is going to end up, she's not going to have any buccal plate there. There's going to be very little on the lingual. So what I'm worried about, let's go back to the pan view of this.
Right over,
Or
sir.
actually the 3D view might be better. And let's
All
look at and blow that up. So Dan, the problem is that bone is going to resorb or be lost all the way down to probably the midpoint of the root on number 8. And that's going to compromise the lateral also. So with that being said, this is going to be a really, really difficult case to graft, and it might even be one that it might be almost impossible to graft to build it up to where you have a FP1 type of prosthesis. With a high smile line, I think were you thinking a single implant there?
Well, initially, that's what the thought process was. A single
Okay.
implant. Concerns of mine were the amount of infection in the site. Um, the as you've taught us, the idea of trying to get any sort of a vertical graft to this would be difficult, and I just quite concerned about the whole bone support.
Yeah. So here's my gut feeling on this one. I think the extent of bone loss, the extent of infection, the extent on what you're going to have to debride after you take out the tooth, and the resultant 4 socket graft, and it might even be a 3 socket after you're done with all that, is going to be unbelievably unpredictable. And it's going to be a rather significant defect there. Um, if I look at her, let's go back to her smile line.
Here you go, Professor.
Okay. And there was another, oh, let's leave that photo. So, Dan, did you think of this possibility? Remove 6 through 8, prep, extract 9, and prep 10 and 11, and just do a 6 unit where all the teeth would be the same size. The right and the left would be congruent. And I think the smile will be 100% better than what any single implant might do for you, even if it would work. Okay. Does that make any sense?
Yeah, when I looked at the aesthetic presentation on this case, I was not happy with 6 through 8 anyway. The mesial
It,
distal width of 8 is inappropriate. So looking at it, canine to canine, I looked at the my what am I should I be concerned about the surgical defects going to be left after 9 if I can't
yeah. So
graft
I
that
so
site?
let so here's what I would do on that site. is, and this is a rarity. You'll probably never hear me say this that often, but what I would do is I would explain to this patient that the possibility of placing an implant here, the blood supply is compromised, the bone is compromised, the soft tissue is compromised. This site just it's not a good site to place an implant. Therefore, I would treat this a little bit differently. You don't want to take out that tooth, debride it, and not put anything in. What I would do is debride it and then use a xenograft. Remember xenografts, they stick around a long time, and a lot of times they don't resorb. They stay a xenograft. That way, it will plump up the tissue. You'll maintain that tissue, and it will be more of a bone graft for the soft tissue for the ponic area. Okay. If
Yeah.
you put an allograft there, that allograft is, you'll probably get some bone fill, but it's going to remodel a lot more apically. Whereas if you use a xenograft, it won't.
Okay.
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 Another option that you could do is Glidewell has a calcium phosphate, which is an alloplast. And uh, what you can do is it comes in like a putty form, and that would fit really nice on the facial, and you could contour it real nice. That again really will not resorb and will maintain that soft tissue. So those are two options for that. Okay. But
Okay.
I think that you could make this patient a very nice anterior 6 unit bridge that would be 100% better than what she has in there. And it would fix that left side. Because I can guarantee you with that smile, that's an exaggerated smile. I bet you she probably doesn't do that smile that high normally.
No, she doesn't.
She's probably protective, and she's learned that. And what I would do is, and I know you're extremely meticulous, and I know you'll do a good job at it. I would start out in the interim prosthesis and start out with a very nice, you know, 6 and 11, same size, 7 and 10, same size, 8 and 9, the same size. Okay.
Oh, yeah, for
So,
sure. The
so
asymmetry to her anterior aesthetic presentation was, I noticed it right off the bat too.
yeah, yeah.
And I
I
think
just
that
it just looks too protrusive on that right side and retrusive on the left. And I think that you can, if you look at number 11 or 12, see how that's in
yeah,
buckle version a little bit.
yeah.
So I think you'll be able to make this and make 6 maybe a little bit more lingual version or not as thick. And I think that you'll be able to do a great, I think you'll change this patient's life actually, Doc.
Okay.
But you know, 9 out of 10 people will try to be a hero and say, I'm going to graft it. You have a 24-year-old girl that it's not going to work. And even if it does, aesthetically, it's going to be a mess. I would use one of those two bone graft options, and I'll talk to you about that in person, because there's a different way that you have to position this so that the soft tissue is elevated and it stays that way. So,
Absolutely.
okay,
I'll get a hold of you
okay,
secondarily to get some help on this case.
okay. Any other questions? Okay, good, perfect. Okay, thank you, Daniel. Next case.
I think we're done for the day. Let me call Dr. Mahima Gupta one last